Vaginal birth is preferred for the first-time mom with a single baby near the due date in the correct head-down position, the nulliparous, term, singleton, vertex pregnancy, or NTSV pregnancy. The alternative, cesarean birth, can be life-saving for moms and babies in certain cases. As the rate of cesarean birth remains high, our goal is to strike a balance. It is important to assess for overuse of cesarean birth when a vaginal delivery could have been safely achieved, while also not failing to rescue an infant in the process of labor and delivery when a cesarean birth would benefit mom and baby. Ensuring cesarean birth happens for the right case, the right reason, and at the right time. Moms who deliver vaginally for their first birth have a high chance of having a repeat vaginal birth in a future pregnancy. And moms who have a cesarean delivery for their first baby are at a much higher risk of having a repeat cesarean birth. And cesarean birth is major surgery, increasing health risks for women, such as pain, hemorrhage, infection, blood clots, and abnormal placentation in future pregnancies. We know that there is a gap in cesarean rates among populations by geographic location, hospital type, income, and race ethnicity. Place matters. We know there is a large variation of C-section rates among hospitals based on race and ethnicity. Black women do not come in with inherent medical risks for cesarean, but we may see still higher rates of cesarean births among Black women. There can also be perverse financial incentives encouraging increased cesarean births. It's not a secret that reimbursement for cesarean delivery is higher than that for vaginal delivery for some practices, some payers, and for various reasons. This may incentivize some practices or providers to elect for cesarean birth based on a desire to avoid a poor outcome or based on increasing productivity on a labor floor. For this reason, rates can vary by shift, provider, and location. One key change idea centers around culture change on the labor floor, specifically related to continuous labor support and patience with labor, also called practicing physiologic humility. Another key change idea centers around optimizing operations on the labor floor. This includes ensuring that patients and families are engaged in shared decision-making, use of objective language among clinicians to describe fetal status and reasoning for performing a cesarean, and team huddles or safety pauses prior to a procedure to discuss why it is being done and what concerns may be related to this specific delivery. Additionally, hospitals should examine policies to support trial of labor after cesarean or TOLAC and ensure there is available expertise in instrumented vaginal delivery. And finally, a key change idea centering on outpatient care is to ensure that providers are working with patients to optimize health during prenatal care and to minimize complications during delivery.
There are 4 important things you can do to get started with this effort. First, as with any improvement effort, you should start by identifying who's on your team and what is everyone's role, and how will they all work together to eliminate overuse of cesarean births and promote vaginal births. The next thing you should do is review your facility's cesarean birth rates. Look at your data by type of cesarean. For example, track your nulliparous, term, singleton, vertex, or NTSV cesarean birth rates, and the number of women who have a vaginal birth after cesarean, or your VBAC rates. These data will help you determine whether your organizational culture is one that supports vaginal birth overall. Then review your mode of birth data by clinician, by time of day, and by race and ethnicity. Know your cesarean birth rates across the population of women that you care for, and identify where there's variation and inequities that need to be addressed. The third thing your team should do is review your policies and procedures. In particular, ensure women have access to freedom of movement and labor support. Also be sure that women who receive epidurals are being turned frequently and that you're using spacing balls or peanut balls. Those are all evidence-based methods for helping reduce cesarean birth rates. Finally, create tools for patient and provider education. Women need to be informed about the short and the long-term risks of cesarean births and the benefits of spontaneous labor. Providers should all be informed of the resources available to them and have the necessary skills to support vaginal births. At a minimum, you should know your facility's NTSV rate and understand where variation exists across clinicians, shifts, and patient race and ethnicity. Make sure there's a policy in place at your facility that encourages non-pharmacologic labor support and patients with physiologic labor, or what I call physiologic humility. You also need a policy on how to interpret fetal status using objective terminology. CMQCC's pre-surgery decision checklist is particularly helpful. That checklist was developed based on the SMFM and ACOG guidelines and is included in CMQCC's toolkit for supporting vaginal births. The ACNM Birth Tools includes wonderful tools, and there is also the ACOG Council on Patient Safety AIM bundle. A1 and ACOG practice bulletins on fetal heart rate tracing have really important statements about offering intermittent auscultation and how to interpret and manage fetal heart rate tracings. We also recommend reviewing ACOG's committee opinion on approaches to limit interventions during labor and birth and A1's position statement on labor support.